পিপিটিটা খুলছে হয়েছে, ঠিক আছে।
Yes, so on behalf of the institution, I would like to welcome all of you, as well as our respected principal sir and our most esteemed guest speaker, Dr. Payel Talukdar madam, who is the head of the Department of Psychiatry, RG Medical College and Hospital. Welcome, ma'am. We extend her a very warm welcome on a warm afternoon. And ma'am, please. For her felicitation, I would like to request our principal sir and Professor Dr. Shubhamoy Ghosh sir to kindly come and do the honors. And then we will have a small opening song as requested by madam and all of us. And then we will proceed on to the main. We have had a seminar of AI for the past 2 days. Let us now think about ourselves also, our intelligence and our psyche. Oh, yes, of course, we will begin with the garlanding of the bust of Master Samuel Hahnemann, as this week we are celebrating as his birthday celebrations. Madam, please, garland.
গান গেনি আমি এখানে বসছি, অসুবিধা নেই। ও করে নি ততক্ষণ। তুমি হ্যান্ডমাইক নিয়ে
তুমি এটা বের করবো না,
কি আসছে না
ইউটিউব
মেল থেকে দেবো
যেমন হয়ে যাচ্ছে।
হ্যাঁ,
হয়ে যাবে ম্যাম।
আচ্ছা, তাহলে গানটা স্টার্ট করে দিই এদিকটা থেকে। আমি সোজা বসছি
না না বসুন।
আচ্ছা আচ্ছা,
ভিতরে আমি দিচ্ছি। এটা ক্যারাওকে আছে, পাশে তো ক্যারাওকে না না আসলে ক্যারাওকে মোবাইলে সিস্টেমের এটা ভলিউমটা আবার বাড়াতে হবে। হ্যান্ড মাইক দিয়েছে, এটা ঠিক আছে। হ্যাঁ ঠিক আছে, হ্যান্ড মাইক
আমি বলেছি
পূর্ণ করো দহন দানে আগুনে জলশ্বরী আমারে দেহ খানি তুলে ধরো তোমার ওই দেবালয় প্রদীপ আমারে দেহ খানি তুলে ধরো তোমার ওই দেবালয় প্রদীপ নিশিদি আলোক শিখা জ্বলো গানে নিশিদি আলোক শিখা জ্বলো গানে মধুর পরশমণি প্রাণ নয়নে দৃষ্টি হতে বুঝবে কালো যেখানে পড়বে সেথায় দেখবে আলো নয়নে দৃষ্টি হতে বুঝবে কালো যেখানে পড়বে সেথায় দেখবে আলো ব্যথামো উঠবে জ্বলে ঊর্ধ্বপানে ব্যথামো উঠবে জ্বলে ঊর্ধ্বপানে আগুনে পরশমণি প্রাণ এই জীবন পূর্ণ করো এই জীবন পূর্ণ করো এই জীবন পূর্ণ করো এই জীবন পূর্ণ করো দহন দানে আগুনে পরশমণি প্রাণ
তুমি সেট করে দাও যদি ঠিক করো, আমি তোমাকে invite করে দিতে পারবো? তুমি কি বলবে? Shit. না, ঠিক আছে। Good afternoon, everybody, and thank you, organizers, principal sir, and other faculties, and especially Dr. Sudeshna, for giving me this opportunity to say about bipolar disorder in this prestigious week of Dr. Samuel Hahnemann birthday celebration ceremony. So I'm grateful to all of you. And 30th March, we have celebrated World Bipolar Day. And that is also a birthday of Van Gogh, Vincent Van Gogh. It was very lately diagnosed as, he was diagnosed as bipolar. At that time, that diagnosis was not there. But lately, we have understood that maybe he's a case of bipolar. And those who are already aware of that illness, it's okay. But those who are not, from the term, you can understand that there is bipole. To understand easily, up and down. What we are doing, we are in the baseline. Some are up symptoms and some are down symptoms. But many times they are coming back to normal. So we call this disease as episodic. This is the most important thing. It is not continuous as schizophrenic psychosis, which is mostly continuous illness. And bipolar, when we have to differentiate from other diseases, this episodic pattern is very important. And when the patient is in the baseline, in the normal part mainly, you cannot just see and look at the patient, and even you talk with the patient, many times we cannot understand whether he is having any problem or not. It can be such normal. But when the disease is there is a great problem. So now you can understand it is a chronic illness, but treatable, manageable, but not curable. And it is so important. You must have heard that IDEA scale, what we do, Indian Disability Evaluation Act. There is a scale from where we calculate the percentage and give that disability certificate to the patient so that he can get some facilities or opportunities, including some financial benefit monthly. So under this IDEA scale, bipolar is a disorder. Others are schizophrenia, obsessive compulsive disorder, and dementia. These all four comes under IDEA's Act. So the gravity of the symptoms and also the duration of illness, all this matters in this scale. And with that, we calculate the percentage of disability and give the certificate. Okay. So you must know this is very important. So now coming, what is the uniqueness? After coming here, we are discussing about the precision. In homeopathy also, there is something called constitution. Every person is different. Same here. If you have some person having a severe chest pain, admitted to a setup hospital or nursing home, diagnosed as acute myocardial infarction, there are guidelines. So you have to do all these things one by one. Do these things and investigations, and when you get the result, you have to do all these things. But in your case and in psychiatry also, every patient is different. Every child is different. Every adult is different. Why You all know, you all studied constitution. So the genetics, the birth, the early years of life, the childhood adversities, the parenting, the school, the education, the coping skill, the resilience. You must know resilience. What is resilience? Coping, managing a stressful situation, and then bouncing back. That is resilience. So all these things are different in all people. So we have to target that. We have to focus that. And we have to make a treatment plan for every patient, every individual patient. There comes the precision psychiatry, or in your treatment, what you have done in your homeopathy, all the patients are different. And that's why you are taking a detailed history, a much detailed history, starting from food habit, lifestyle, sleep pattern, bowel pattern, everything. So why the uniqueness? Though just because the two people have the same mental illness, that is bipolar, that doesn't mean that they will need the same treatment, react to the medication same, display the same symptom, need the same type of support, have the same medical and personal history, and have the same means. How they want the treatment, everything is different. So we have to think and have to make the guideline individual for individual patients. So all these things are different. The genetics, the diagnosis, which part is there, bipolar 1 or bipolar 2, or it is substance induced, you have to have a clear-cut idea. And when choosing what molecule, which molecule we have to prefer, for how many days, we have to see how the side effects are going on, how the patient is reacting to that, what is the outcome of the treatment, whether patient is getting a benefit or not, or whether he is getting the side effects from that medicine, then we have to change. So the guideline is applicable with the individualization of each patient, and also the medical and personal history and other things. But we should be aware. I have already told bipolar disorder is treatable. It may be manageable. It is not curable. But one thing that is very important, it is a treatable condition. There is no shame in seeking help. And recognizing mood changes early. Whenever we are diagnosis, if we can diagnose a disease or disorder early, so we can do better for that patient. Early diagnosis is very important in all aspects, in all therapies, in all types of medicine. And watch for early warning sign like reduced need for sleep, irritability, or sudden energy shifts. Don't stop medication without medical advice, and maintain a regular sleep schedule and daily routine. That is very important. And avoid alcohol and substance use. I will come to that later. And talk openly. Don't suppress your struggle. And stay consistent with therapy and medical follow-up. Seek immediate help in case of suicidal thoughts or severe symptoms, and work towards reducing stigma in families and society. All you agree with this? And there should be no judgment. And one thing we have to remember, that it is not the only mood swing. Many people come to us and say, doctor, I have mood swings. So mood swing is not bipolar. We all have mood swings. In the morning, we may be that we are very depressed. But in the afternoon, we get a good news. We get a good opportunity. Our mood becomes normal or elevated. That is mood swing, the day-to-day variation. But when it is creating distress to the patient, disability to the patient, then it is important. So distress and disability, these things we have to keep in mind. What is the role of psychotherapy? Because when we are taking the history and talking to the patient, from that time, the psychotherapy begins. This is not that we have diagnosed, we send the patient to the therapist give a date, then he or she attends the therapist, not like that. When we have started taking history and talking with the patient with his or her struggle, from that time, psychotherapy and obviously the rapport with the patient, that starts building. So psychotherapy helps understand the betterment of the condition, identifies the trigger. The trigger is very important, and pattern of mood changes, builds coping and emotional regulation skills, addresses negative thinking in depression, improves medication adherence. This is very important because in this case, non-compliance, the patient is not taking the drug. He thinks that he is okay. The family members are making him sick. They are making him so-called pagal. So he will stop the medication. These things are very important. So medication compliance and the daily routine, maintaining of the sleep and other issues to the routine structure is very important. And support the healthy sleep and daily routine, improves communication and relationship. And relationship issues and triggers from the relation is very important in exaggeration of the symptoms. And the new episode is very important when the person is having some stress, triggers in the relationship or in the workplace. These two things are areas are very important, workplace and relation. Okay. And strengthening of the family support. For this also, therapy is very important, family therapy. Now, what are the diagnostic dilemmas? So most common, as we all know, that is unipolar versus bipolar. So 50 to 70% of the bipolar patient first present with depression. So first patient has come to you with low mood, lack of energy, and anhedonia. So what is anhedonia? It is lack of pleasure in usually pleasurable activities. I am very fond of this serial. I'm not now, I have no interest in that. I even do not touch the newspaper. I do not want to talk with the other people. Those two things that are very pleasurable to me, I don't like now all these things. So this is the anhedonia. And 50 to 70% of bipolar patient first presents with depression and hypomania. This is very important. This is often unrecognized because it is not full-blown mania. The patient has high energy. He is doing a lot of work, maybe a lot of creative work. So people are happy. The patient is happy. The family members are also happy. So they are not coming to the doctor and they are not communicating with the doctor and seen as normal high functioning, not reported unless specifically probed. So you have to ask. There are some period in your life, in your time, that you are having more energy than normal. You are doing more creative works. You are not sleeping properly. You are having some amount of irritability. These things you have to ask. Then the bipolar 2, that is the biggest diagnostic trap, because as we already discussed, that hypomania is egocentric and subtle changes are there, and patients seek help only during depression. So hypomanic part, he is enjoying. He, not only he, his family is also enjoying that hypomanic part. So they are not reporting. When they will report only in the depressive phase. And this leads to long-term delays. So what are the conditions that can overlap or come in disguise? So that is major depressive disorder. First patient come with a depressive episode. Most of the time we think that it is a unipolar depression. Even this is also possible that this is the first episode. There may not be any hypomanic episode. This is the first episode. But we have to be very careful. I will tell you in other slides. So major depressive disorder, they come with similar depressive episodes. Borderline personality disorder. With this, there is mood instability, impulsivity. These things are very common in borderline. But these things are continuous, not episodic. It is happening from early as adolescent or early adulthood. Person is continually like that. There is no episodic phenomenon. Substance abuse due to mood swings, intoxication, withdrawal, and other things. So you have to be very careful about taking the substance abuse theory. I will come to this later on. And also the schizophrenia, there is psychotic symptoms, because when there is manic full-blown symptoms, it may be associated with psychotic symptoms. They lost insight and judgment, and there is delusion. You all know delusion? That is false firm belief that is not amenable to logic, that some person is doing a conspiracy, my neighbors are not good, they are always jealous, and many other types of delusion, like wizard type delusion, that is also possible, that somebody from outside the world is controlling me, these things. Or maybe I have some extra power, like I am next to God. This is not possible. This is grandiose delusion. This type of delusion may be present. And there is switching phenomenon. We think that this is a case of unipolar depression. And I have given him antidepressant. He is not doing well. I have added another antidepressant. The patient came with hypomanic or manic symptoms. So this is antidepressant-induced mania or hypomania. So this is what happened. I have to give the antidepressant for a depressive disorder, but the patient has a hidden bipolarity. It is not possible for me at that time to understand that or recognize that. So the thing what happened, that is antidepressant-induced mania or hypomania. So when there is switching, that time we can understand that no, it is not a case of unipolar depression. He has bipolarity. But there may be spontaneous mood switch. The patient is getting drugs. Patient is even getting mood stabilizer. Not only antidepressant, patient is getting mood stabilizer. Still then, the patient can have mood swing. So in spite of proper treatment, the patient can have episodes of mania or hypomania or depression. And there are rapid cycling when there are four or more episodes in a year. So this is a very critical case, rapid cycling, and often associated with antidepressant use. Thyroid, that is very important. In all the cases of mood disorder, you should always take the history whether the patient is taking any this type of medication, or if it is not, just go for thyroid profiles and female gender. These things are very risk factor for rapid cycling. So what are the predictors of bipolarity? Course-related predictor. So early age of onset, when it is very early, below 25, and the person is having recurrent depressive episode. Abrupt onset and termination. You are not understanding why that patient is getting a very good outcome in a very short period of time. Abrupt onset and termination and short depressive episode. Next comes the symptom profile. Hypersomnia. Not the insomnia, hypersomnia. Patient is having a lot of sleep. Hyperphagia, increased appetite, psychomotor retardation, psychotic features, and mixed features. These all are predictors of bipolarity. So when the depressive patient is coming with all these things, hypersomnia, hyperphagia, psychomotor retardation, psychotic features, and mixed features, you have to be very careful about bipolarity. Now coming to the family history, which is very important. Strong predictor of bipolar disorder, if there is on maternal side or paternal side, and there is a history of completed suicide in family, and also attempt. You have to probe that, whether there is any history like that. And treatment-related clues, that is poor response to antidepressant. You are giving antidepressant, 1, 2, even 3 antidepressants are added, but patient is not getting well. His mood symptoms are not improved. Then you have whether I am missing the diagnosis of bipolar. He may or she may need a mood stabilizer. And antidepressant-induced agitation, irritability, and mania, you have to keep a close watch about that. Now coming to the temperament and personality. Few people are having cyclothymic temperament. Their mood swings are very common. So you have to take a good history, whether he or she is having just a low mood and high mood, or whether he or she is having the criteria fulfilled for hypomania or depression. And few people are hyperthymic. They are over enthusiastic, always in high mood, but his personality is like that. His temperament is like that. His thought, emotion, and behavior is like that from the very beginning. So we cannot stamp this as bipolar. You have to take that episodic history. This person is from the very beginning like that, over enthusiastic, over optimistic. And mood lability since adolescence. From adolescence, because you know, bipolar comes even before 18, before 20. So from adolescent period, you have to take a good history. And behavior marker, episodic impulsivity, risk-taking behavior, and periods of increased productivity or creativity. These things you have to keep in mind while taking the history. Now, practical clinical approach. Always ask for whether there is any period of increased energy, less need or reduced need for sleep. They are not complaining of that, doctor, I am not having good sleep. I have no need for sleep. Only 3 hours or even 2 hours of sleep is enough for me. I can do work for 20 hours a day. These things, these types of symptoms is very alarming because there is reduced or less need for sleep. Overconfidence, elevated mood, increased talkativeness, and also you should ask for collateral history from friends, families, past behavior pattern, and antidepressant response. How he or she is responding to the antidepressant. Common mistakes. Treating recurrent depression. Depression is coming on and on. Treating recurrent depression without screening of bipolarity. I am not asking his family members. He is not giving the proper history. Then we have to ask his family members, his near and dear ones, even his friends. Many people are staying in the hostel or workplace. There is no family member present. In that case, you have to talk to his friends or roommate. Ignoring hypomania. We are not taking the importance history of hypomanic episodes. Mislabeling as personality disorder. Missing the mixed features. So depression, irritability, decreased need for sleep, always think of bipolar. Now coming to the genetics. So bipolar disorder is not caused by one gene. As we all know, the psychiatric disorder, all the psychiatric disorders are polygenic and multifactorial. It is one of the most heritable psychiatric disorders. In general population, the percentage is 1 to 2%. When the first degree relative is positive, it comes to 5 to 10%. When both parents affected, 40 to 70%. And even in monozygotic twins, that is 40 to 70%. So it is not fully genetic. There are other factors. That is why it is multifactorial, and environment is a most important factor. There is no single bipolar gene, and genes can be switched on and off as epigenetic phenomenon. That's environment, the sleep, the total schedule of life, work schedule, and other stress factors. These things are important because these things are not causing the gene changes, DNA changes. There is no change in adenine, guanine, cytosine, and thymine. There is no structural changes in the gene, but there is genetic expression. So that is why it is called on-off phenomenon. If you can modulate the environment, if you can change the environment, then you can improve the case. And factors influencing gene expression is stress, as we all know, trauma, lifestyle, sleep, and diet. These things are very important. And common triggers, sleep deprivation is a very common trigger, substance abuse, and stressful life event, as I have already told, workplace and relationship and family. From stress factor coming from these areas are very important. And if the gene is positive, then the same gene may predispose to bipolar, schizophrenia, depression, any disease can happen. Okay. Now coming to your subject, constitution. So constitution is central part, the individual pattern of functioning, not just the disease, but the person as a whole. Example, two patients with bipolar disorder. One is extroverted, high energy, impulsive, and another is withdrawn, sensitive, anxious. You have to take the history. So diagnosis is same, bipolar, but constitution is different. So different remedy. Agreed. So modern medicine, in homeopathy, constitution is very important. In our allopathy medicine also, genetics, temperament, biology, susceptibility is very important. Here, genetic vulnerability, individualization is everywhere. Precision is now everywhere. Personalized medicine, as you are having, we are also having the same. The two patients, even if we have seen that they have all the factors common, starting from socioeconomic status, financial, disease pattern, still we have seen that the same medicine, same dose is not working exactly in the same way in both patients. Okay. And clinical importance, understanding the constitution helps. How? To predict who is at risk. This is most important. Who is at risk? How can we prevent a manic or depressive episode? Understand why illness develops. Choose individualized and improve the preventive care, whether we can prevent the further episode. What is the motto of our treatment? Why we are so serious about explaining to the patient and family the importance of bipolar. So we want to prevent the further episode, because with every episode, the brain damage happens. In bipolar also, the cognitive impairment. We know that in dementia, there is cognitive impairment, in schizophrenia also, but bipolar, cognitive impairment in bipolar is also very important, very devastating, that we have to keep in mind. So you all know, those who have gone through the psychiatric disorder, you all know the core features of mania and core features of depression. But I am just recapitulating that elevated or irritable mood, increased energy or activity, distractibility, grandiosity, flight of ideas. You are talking with a patient, he is talking about one, immediately within seconds he is changing the topic, and with that word he is going to another. Okay, so flight of ideas are coming. Talkativeness, decreased need for sleep, increased goal-directed activity, starting business, 4 businesses at a time, 3 businesses at a time, taking bank loans and having so many planning in his head. Impulsivity and reckless behavior, these things are very problematic. And also the increased spree. Has very minimal amount in the bank, but he is buying with his credit card. This is very disastrous in nowadays. And also the psychotic symptoms. And the core features of depression, as we all know, that low mood, lack of energy, and anhedonia. These things are very important in depression. And sleep disturbances, appetite changes, poor concentration, feeling of guilt or worthlessness, psychomotor retardation or agitation, both can happen in depression. And obviously, last but not least, that is suicidal ideations. And even in both the situations, whether the patient is in manic phase or depressive phase or in hypomanic phase, always ask for suicidal ideations. Because there is a myth that if you ask for suicide to any patient, the patient may attempt suicide. The patient may think of suicide. That is not correct. You should always, whenever a patient with mood disorder come to you in your OPD, always ask for suicidal ideations. Okay. Now coming to the substance abuse. Both frequently co-occur and worsen each other. What is, it may be the cause or consequence, but both usually co-occur. Up to 40 to 60% of bipolar patients have substance abuse disorder. So leads to more severe illness of bipolar with substance abuse. Now you think both the severe patterns are coming. More severe illness, poor treatment response, and high suicide risk. Okay. Why they are linked? During depression, they want to self-medicate. Whenever we are having low mood, we think that how can we get out of this condition? What can help us? Many people go for substance abuse, mainly alcohol. Okay. I have a relationship breakup. I have some financial loss. So how can I reduce my depression or anxiety? You have seen in cinemas also, they shown that, yes, the hero has a relationship breakup, so he has gone to a shop and taking alcohol. But it is not the solution. But to reduce the depression, reduce the anxiety, people go, takes alcohol. So alcohol and sedative drugs to relieve stress. And during mania, the mania is high, mood is high, and they are also taking stimulant. The stimulant causes more high mood, and also alcohol to have the enhance the pleasure. These things are self-medication. Patient is himself or herself is taking that. And mania leads to poor judgment. So causing experimentation, risk-taking behavior, and addiction. So they have some type of neurobiology sharing like dopamine dysregulation in the mood symptoms and also in substance abuse. You all know that there is increase in dopamine. That's why they are getting high. They are always craving for that. So dopamine dysregulation and reward pathway, you all know, ventral tegmental area and substantia, nucleus accumbens. These things are connected. So they are getting high dopamine. So genetic vulnerability, these things you have to ask both for mood disorder, bipolar disorder, and also for substance abuse. Whenever you are getting a patient of substance abuse, apart from bipolar, always ask for history of family, whether parental side, paternal, both sides, whether there is any, at what age they have started, and whether there is any history of suicide or any legal problem. You can ask for that. Clinical consequences like more severe course, earlier onset, frequent relapses, and rapid cycling with alcohol. Treatment problem, poor compliance. They are taking substances, they are not taking medicine. Drug interaction with substances, and reduced effectiveness of mood stabilizer. And increased risk, increased suicide, violence and aggression, and increased hospitalization. Common substances, alcohol, cannabis, these things are very common in our country. Along with it, cocaine or stimulant and sedative. It is a bidirectional relationship with shared vulnerability. Both are vulnerable factors. Now coming to some case vignette. Okay. If you have any question, we can answer or discuss later on. Let's finish that. You all know now that what may be the presenting symptoms. So a 28-year-old male is brought by family with excessive talking, claims he has a special power, sleeping only 2 hours, but feels energetic, spending large amount of money impulsively, and mood is euphoric or irritable. So what is the diagnosis? Age and the symptoms. You can understand from this case vignette that this is a manic symptom. Okay. So this is the diagnosis. Now with manic symptoms, a single manic symptoms we can diagnose as bipolar 1. There is no need for depressive episode to come. Before that, even if the patient presents with a single manic episode for the first time in his life, you can stamp him as bipolar 1. Okay, so bipolar 1, single manic episode or manic episode along with depressive episode. All will go with bipolar 1. And bipolar 2, hypomanic episode with depressive episode. Okay. Many of us will, first time will miss the hypomanic episode, and with depressive episode patient come, and after that he will have hypomanic episode with the antidepressant. So bipolar 2 is hypomania with depression, and bipolar 1 is one manic episode is sufficient to diagnose bipolar 1. Clear? And when we cover the patient in the long run, we can see that depressive episode are also coming. So manic episode plus depressive episode, the diagnosis bipolar 1. Okay. And antidepressant induced mania, that is a separate entity. And substance induced mood disorder, that is also a separate entity. In that case, the substance is coming first, not the disease. Substance is coming first. And if the patient is abstinent, the symptoms improved. This is the main thing. You have to see the temporal relationship, that when the patient is abstinent for 6, the symptoms improved, patient recovered. So it's maybe depressive, maybe hypomanic, maybe manic. That is not primary bipolar. Primary bipolar is bipolar 1 and bipolar 2, or maybe rapid cycling. But the substance-induced mood disorder is separate. There is clear-cut evidence of mood symptoms after taking substance. Okay. Next, 24-year-old female presents with persistent sadness, excessive sleep, increased appetite, low energy, and history of occasional period of increased energy, talking more than usual, reduced need for sleep, and ask question whether it is depression or it is bipolar. So in that history part, this is occasional period of increased energy, talking more than usual, less need for sleep. You have to probe that. You have to ask the patient. You have to ask the family members. You have to clear that area. Otherwise, we will give an antidepressant and there will be, or maybe a switch. Okay, then you have to manage that. Then you have confirmed your diagnosis. But patient by that time have 2 episodes, one depressive and one antidepressant induced hypomania or mania. And in the guideline, it is told that if you have 3 episodes or more, you have to continue the medicine lifelong. You have to continue the mood stabilizer lifelong. Okay, this is according to guideline. Patient don't want to go for lifelong medication. Okay. Another case, 35-year-old female treated for depression with antidepressants, develop increased talkativeness, reduced sleep, irritability, overactivity within 10 days of treatment. Maybe she is having 2 or 3 antidepressants. So, as you all know, that is antidepressant induced. Okay. So, before giving antidepressant, we are getting that patient is not improving. We are adding antidepressant. Patient can, I am not getting better. My mood is still low. I am not having proper sleep. I cannot do my work. I have not sufficient energy. We are adding antidepressant. So think about, screen for bipolar, think about bipolar. Okay, this is very important. Otherwise, he or she may land in your chamber with a full-blown manic episode. Maybe tied up with hands, with lock also. Okay. Now coming to the case beginning 4, a 32-year-old male is brought with excessive talking, irritability, sleeping only 2 to 3 hours, spending money recklessly, increased alcohol intake over last 2 to 3 weeks, history of similar episodes 3 years ago, drinks alcohol regularly. Okay. So how will the diagnosis? The alcohol, now coming the question, whether it is a cause or it is a consequence. Okay, that part is very important because these things we have told that this is bidirectional. The two can co-occur, but you have to take the detailed history, whether the substance is coming first or whether the episode is coming first. Whether I can tell this is a primary bipolar or it is a substance-induced mood disorder. Clear? That part is very important. You have to corroborate with family member also. A person taking alcohol or cannabis usually they do not tell truth. They suppress the truth, not telling the whole truth. Okay. They will share a few things with, but will not reveal everything with you. That's why you have to ask the family members, near and dear ones, or even roommates or friends also. Okay. So substance use as a consequence of bipolar. It may also happen as a consequence of bipolar. So self-medication. He is not improving. That's why he is taking substance. He can take for impulsivity. The bipolar patients are very impulsive. So he or she may take alcohol and cannabis, or for dysregulation of emotion, for emotional dysregulation. His mood is not what he is wanting. That is a normal mood. He is not getting that. So he is always thinking, how can my mood get better? With what? So he will try for substance. On substance use as a cause, it can precipitate the first episode also. So substance can be a trigger. All of this you have to take in history. Okay, that cannabis, stimulant, alcohol, all can be a trigger. The person was genetically vulnerable, and this cause a trigger for that person to have a full-blown symptom. And this goes for a vicious cycle, bipolar substance worsening. This type of cycle will be there. And another thing is that what are the clinical clues to differentiate? The substance-induced mood disorder, the symptoms will appear first. The substance history will get, then we'll have the symptoms of mood symptoms. And if you have the abstinent period, you can have the therapy or other things and other treatment so that the person just get rid of his substance. He's having a normal life. You are not getting the mood symptoms. Then you are confirmed that it is a substance induced. But you are getting the manic symptoms or hypomanic symptoms or depressive symptoms. And then the person is taking alcohol or cannabis for getting relief. In that case, the substance is worsening the symptoms. Substance is causing trigger. Okay. But the situation is actually primary bipolar. These things are very important. So you have to be a clear-cut history for the treatment and diagnosis. Okay. So these things, the most important things I have covered. There are so many things. And if you have any queries, you can ask me now. Rapid cyclers that have grave prognosis. They have more than four or four episodes in 1 year. Up and down, up and down. They are very devastating. Rapid cycler, 4 or more episodes in 1 year. Okay. These things are rapid cycler. Yes, those are stamped as rapid cyclers. Rapid cyclers, bipolar 1, bipolar 2, rapid cycler. Okay, maybe mixed features also. They are having irritability along with depression, but getting less need for sleep, spending spree more. They will come under mixed episode. Few things are really complicated. And when there is bipolar along with other psychiatric comorbidities, then it is very difficult. Maybe that the borderline personality disorder may exist with that. In a young adolescent, ADHD may come with bipolar. Substance abuse and bipolar. These things are very common. But which thing you will treat first? You will always treat first the mood symptoms. Even if a adolescent or young adult come to you for the first time, you are definite in your diagnosis that he has both ADHD and bipolar. Then keeping aside ADHD, you first treat the mood symptoms. both present with attention difficulty. But you have to treat mood symptoms first, because if the patient went to a manic episode, that will be devastating. So you have to take care of mood symptoms first, then you take care of the ADHD part. Okay. These things are very problematic, along with borderline personality disorder. Borderline personality disorder, from the very beginning, the patient is emotionally unstable. Always thinking that nobody supports me, nobody loves me, this type of symptoms, impulsivity. Both of them have impulsivity problem. But borderline personality disorder, chronically, they have the same problem. Ups and downs is always there. In the morning, she is up. In the afternoon, she is low. And this type of variations. With when she is having is positive outcome, she is happy. She is happy when everybody takes care of her. Everybody is going by her decision. There is no problem. In Berlin, we have seen the patient has no problem. The person who is surrounding her or him, they are having more distress. Patient says that I want this one. You have to give me. Okay. His family member is saying that it is not possible now. I will give you later. Please give me some time. But the problem remains. She is having problem. So these things are chronically present from the very beginning. But here you will get the definite episode. If you have a chalk and board, you can clear cut. You will have a baseline. The person will come back to the baseline. This is clearly episodic. If you can treat the person, properly diagnose the person, can give the proper medicine in proper dose, the person, in whatever situation he is there, he will come back to the normal. Maybe that after 10-15 days, he can go back to manic or depressive, but he will come back. He will come back to the baseline. So it is not at all a continuous illness. Yes, continuous and episodic. This part is very important. So the history from the family members, collateral history, this part is very important. How he is doing at home. How he is in last 5 or 10 years. How he is doing. Whether it is episodic or it is chronic. Many times it happened that hypomania, never targeted, never focused, never treated. The patient comes with a depressive episode first. What we have told, that patient comes with a depressive episode, but you have to take the previous 5 years, 8 years history, whether he has any hypomanic episode or not. In our hurry, we forgot to take that history. We have given antidepressant. Okay, the patient is not getting better. We have added another one. Then patient comes with a hypomanic or manic episode. Because this bipolarity indicators you have to keep in mind. The patient is having hypersomnia, patient is having increased appetite, psychomotor retardation, is not responding to more than 3 antidepressants, and the patient having postpartum onset. We are discussing previously. If the patient has postpartum depression history, you have to go for a long follow-up. It may turn up to bipolar. Postpartum, that after the delivery, patient may have postpartum blues. That is self-limiting. The patient can manage. She will get better by herself. She will have problem, low mood, irritability, low energy, but somehow she will manage. The role changes. And the responsibility of a newborn, she will manage. But next comes postpartum depression. That is many a times under-recognized and under-treated. Okay. So the person's quality of life falls. The person suffers throughout. But in the long run, the research shows that these postpartum depressions end in bipolar disorder. Mostly. Okay. But unfortunately, she is having long period of untreatedness. We have not treated her. We have not focused her mood symptoms. we have not focused her struggles. But she is struggling. Her family members are also not responding to that. They are not understanding that. Okay, because marriage and childbirth is always stamped as a glory for us, glory for our woman, but certainly not in our country like India. Childbirth is always a stress in a country like us, separate from Western world. Marriage and childbirth. You are very young now. Maybe some of your friends are already get married or in the village or in the town also. You see what struggles they are having. Okay. Agreed or not? You are laughing. I am telling from my own experience and everyday outdoor that people coming with their daughters 16, 17. Okay, married, even with one child, and so many physical symptoms. So what should I tell them? That they are supposed to go with a backpack with the college. And now they are having their life in kitchen and child and in-laws and husband. And most of the cases, the husbands are having substance abuse. They are physically and mentally tortured, everything. Intimate partner violence, very common. Domestic violence has gone to such an extent. The people thought that it is a normal phenomenon. Many a times. The wives can be beaten. Okay.
Are the other psychiatric disorders that happen most frequently coexistent with bipolar disorder?
Now, one thing is ADHD. Bipolar with OCD may come. Bipolar OCD, bipolar ADHD, then substance abuse. Both can coexist. Okay, and bipolar with borderline personality. These things are very common and very critical to treat.
As per your experience, what is the long-term outcome of such patients under drug therapy who are pursuing routinely, regularly, persistently drug therapy? What are their outcomes?
They are getting regular treatment.
Compliance regular.
Compliance is usually not good, as because patient comes and tells us, I am having normal mood now. I am doing my job properly. I am in baseline. I am not having high symptoms or low symptoms. Why I will take medicine? You are telling that your next episode can come at any time. It may come after 6 months. It may come after 6 years also. So how I will agree to take medicine for so long period without having any symptom? This is the main problem with the compliance. If the patient himself understands that whenever I am off medication, I am getting symptom, at that time he is ready to take. He is seeing that whenever I am off medication, I am not taking any medication, only I am taking the sedative drug, clonazepam or other things. And that is also I am buying for my own without any prescription. I am doing well. That part is okay to the patient. But when the patient himself or herself understand that whenever I off medication for 1 month, 2 months, then the symptoms are again coming back, then the compliance gets better. Family members also understand that I have to give this person 1 or 2 medications daily to keep him better for the long time. And in the long run, the cognitive impairment is a very important factor. Similar for schizophrenia, after 40, 45, they are getting better. But the cognitive impairment persists. And this causes very problem in workplace. Workplace problem, those who are doing that type of table work, job with computer and other things, office works, For them, the cognitive impairment is a big issue. But non-compliance is a very important factor in bipolar. They are switching to substance.
আমরা যদি ধরে কারো ডায়াগনোজ করেছে 15 বছর বয়সে এবং সে কমপ্লায়েন্ট পেশেন্ট, সে রেগুলারলি ট্রিটমেন্ট করছে, তো at 40-45 will she also have a similar cognitive impairment like those who are non-compliant to that extent?
Cognitive
Or what is the
impairment
outcome
will
in future?
cognitive impairment will be high those who are non-compliant. Okay, because with every episode, the cognitive impairment happens in the brain. And for bipolar, there is a phenomenon called kindling. Kindling phenomenon. The first episode needs a lot of stress, but when the subsequent episode are coming, they need very less stress. Even without stress, they can come. The brain becomes susceptible. And this kindling phenomenon happens to bipolar and also in epilepsy. Kindling phenomenon. So this happens when that child developed at the age of 15, but he or she is getting a long-term good rational treatment throughout the years. And the most important thing is his environment and therapy. That is, we are discussing that for bipolar, there is interpersonal and social rhythm theory. That is very important. You have to keep a good social structure and daily routine. Sleep, diet, lifestyle, food, everything should be structured. Keep a clock-like routine. This is very important. Social rhythm and biological rhythm and good functioning family is very important. If the family itself is dysfunctional, there is so many problems in family, then it is very difficult to keep him, that patient good. The family itself is dysfunctional. There is substance abuse in the other members of the family. There is everyday quarrel, everyday problem, financial issues. These things are ongoing stress. Stress and trigger, trauma, these things are very notorious for bipolar. Relationship break may cause a new episode.
Yes.
We can think that what is a trigger, what is a stress, but the stress also is different to every person. We many a time, whenever a suicide in metro happens, we thought that, ওফ লোকটার টাইম পেল না, এই সময় সুইসাইড করলো, বা এ কি আছে এদের সবেতেই এরকম, we comment like this. But the cause that has gone with that person, we never know. We only judge. We never judge a person because the stress is also perceived differently for a different person. And every person wants to live. Nobody wants to die. But there is no one to stand by my side and there is no solution to my problem. That's why I have decided to leave this world. When the patient rescued or recovered, then they told this type of things, that I have no one to support. I have no solution to my problem. There is no one who has caught my hand. I am alone. Even if when I am jumping, nobody has come to rescue me. And every day, you will be astonished that in India, every day, 35 to 40 students from the school to university. I'm just talking about the students from school to university. Every day, 35 to 40 students are dying by suicide. Every day in India. We are getting the suicide news from the premier institute like IIT and other things. They are coming to the newspapers. We are not getting the small news and other from the every corner of the country. So every day 35 to 40. So just calculate the yearly picture. The suicide picture has changed after COVID. The daily wage earners, the housewives, that's why I have told that marriage and childbirth is really a stress for us. Housewife suicide has gone up much more. And even this is also happening. They are dying by suicide with their children also. And we now tell that died by suicide to destigmatize the word. We are now using that, not using the term committed suicide. Always tell that he or she has died by suicide. If you have gone through the newspaper, that they are also using that term. The person has died by suicide. They are also not using the term committed. Okay. And in our country now, recent Mental Health Act has decriminalized the suicide. Previously, if anyone has attempted, there are some police case and other things happened, harassment. Now, the suicide, those who are attempting, at least the process has simplified, and it is told that that person must have some problem, must mental disorder or other stressful issues. That's why he has attempted that. It is not that he has committed some punishable issue. Okay. Suicide is a very big important factor. So always ask for completed suicide in family, and the person whose history you are taking, always ask for the suicidal ideations and attempt, whether he or she is thinking of doing, because it has been seen that many a times they come to doctor, they are thinking about some plan and other things, and they just came to the doctor to discuss that, to ventilate that, and the doctor is not asking about that. So they will not disclose, they will not open up. He or she has gone to you so that he or she can ventilate to you. Okay, but you are not asking about that. You are not asking whether you are thinking of killing yourself, finishing yourself, whether you are thinking that it will be better if I am not alive in the next morning. This type of things thinking. You are not collecting the medicines. Many a times from different shops, they are collecting the sedative drugs from different shops. 80 to 100 clonazepam tablet. They are accumulating for last 1 month. So we told the parents that don't always correct your children. Please connect with your children. That is the most important thing. You are giving, so you have to do such things, you have to get this type of marks, you have to do this thing, don't do these things, so many things. But do you ever just sit by your child and talk to him or her whether what is the problem he or she is getting in the class or in the field or in the home? Even the child is now playing or having some karate class or a swimming class. There is also their thing. You have to come back home with the medal. That play, the simple play, what we prescribe, always go for playground, don't use your screen, go for swimming, go for karate, just run, have a football match, anything. But parents are telling, no, you have to come with a medal. You have to come with a certificate. So many things. No, you just think of these things. No, these are getting day by day. These things are getting worse and worse because the parents are also in huge pressure. They are also in huge pressure, and that pressure is going to the child also. Okay. Agreed with that? Whatever discussion we have, do you agree with that? So think about these things. If you can be a help with your colleague, with your peer group, with your friends, be a help to that. What we call it a gatekeeper training in suicide prevention. So everybody can be a gatekeeper. If in a cook, kitchen cook, darwan, they can be a gatekeeper because they usually see that whether the student is coming for food every day to the mess, whether he is going to the classroom. Many a times they have to break open a door and take out a body. For 3 days, nobody has stressed, nobody has searched for him or her. Okay, so gatekeeper training is very essential because the gatekeeper who is in the ground floor of the hostel, he knows that who is going out for the class, who is not coming out for 1 or 2 days. So there must be some alert, some red flag, that so that we don't have to discover the body, not that student, after 3 days in a mutilated condition. Okay, just think of these things. Be a help to your fellow, whoever it may be, your friend or your colleague, anybody. Be a help to others. Okay. Yes, good.
One question.
Yeah, sure.
In bipolar presentation, there is certain set of symptoms alternating each other, or always coming some new group of symptoms.
Usually with the same symptoms and what we call early warning sign. The family members must know that. The early warning sign, usually the presentation is similar in all the episode, but with age, they can differ. Suppose a 16, 17-year-old bipolar will present in a way, but when that fellow becomes 25, 26, he has his own job, he has his own money, it will be more risky behavior, more impulsivity, more chances of substance abuse. 15 years, he is in a school. He is in a routine structure, totally guarded by his parents. But a 25-year-old person, maybe away from his home, in another city of India, having his full money, salary, with every scope of risky activity, increased sexual behavior, and substance abuse. That's why the presentation may change with age. Are you satisfied, sir?
Yes.
Oh, okay.
ম্যাডাম
হ্যাঁ।
এই সাবস্টেন্স অ্যাবিউজ যদি না হয় এখনকার দিনে দেখা যাচ্ছে যে শুধু এক্সপেন্ডিচারটাই বাইরের প্রত্যেকটা রেস্টুরেন্টে এফবি তারা বারণ করছে কিন্তু প্রত্যেকটা রেস্টুরেন্ট ডিফারেন্ট এত রেস্টুরেন্ট রয়েছে রেস্টুরেন্ট সে খেয়ে বেড়াচ্ছে আর তার কি হাইপোম্যানিক অর ম্যানিয়াটা বাড়ছে তার সঙ্গে ইরিটেবিলিটি হচ্ছে এটা কি বাইপোলার হিসেবে নিয়ে
Food addiction. Age of food addiction, this also causes dopamine high. These are the behavioral addiction. What we have discussed, that is the substance, that alcohol, cannabis, stimulant, and other things. And these things are, that is gambling, shopping, online shopping, food addiction. All these are causing dopamine high. Same effect in the brain, same circuit. Pathway is the same, the neurobiological same circuit. Yeah. Ekdom. All the behavioral, all behavioral. The most important thing is losing of control. This is the first thing in substance abuse. When everybody plays games in online, but when you are losing your control, that is the early indication that you are trapped. That phone is controlling you. You are not controlling the phone. It is a smartphone, but you cannot use it smartly. The phone is reversely controlling you. Up to 2 o'clock at midnight, I am with my Instagram and Facebook.
That's all.
We are getting porn addiction even at the age of 12, 13, 14, 15, all the age groups. Porn addiction, adult films. Guardians do not even know that. It's a very common nowadays. And coming with dissociative symptoms, conversion disorder, physical symptoms, academic failure, going out of home, fleeing with Facebook friends. These things are devastated outcomes. All are behavioral addiction because there is no bar, there is no restriction. If you have a smartphone and an internet, you have everything in your hand. But how you are perceiving that? At the age of 12, you are seeing an adult film. How you are perceiving? You have taken the knowledge of gender and sexuality from the phone, from your peer group, Those who are also 12 years, 13 years old. So you are totally getting a wrong perception, wrong idea about sex, sexuality, and gender. Everything.
But actually, I have two patients.
Mhm.
Diabetes for near about last 20 years, and I've gone for the different cardiac surgery. And
Cardiac surgery, stent or bypass?
bypass, and previously was stent, followed
Then
by
bypass. Okay. Okay.
Now he is under the near about 12 to 13 minutes.
Okay.
And for last 3 to 4 years, showing the bipolar. Whether any
How old?
age is 67 years. So my question is, madam, any other medicines that particular patients are taking every day have to take, whether that causing this kind of the bipolar?
Then you have to go through all the medications. So medication induced some mood symptoms. You have to go through all the medications, but at the age of 67, you have to first think of dementia before stamping the patient bipolar.
But patient not
May have history of bipolar when he was in 30s, 40s, 50s. But when he has crossed 60, already he has cognitive impairment for long drawn psychiatric illness. In that case, you have to first go through his cognitive assessment. Okay, because behavioral and psychological symptoms of dementia most of the times have the resemblance with this type of mood symptoms. Anger outburst, irritability, not having proper sleep, agitated, aggressive behavior. These things are very common. So we thought that, okay, this must be the continuation of bipolar, but you have to screen for dementia. As because he is having heart issues, must be having hypertension and diabetes, he is having long drawn, so he must be suffering from vascular dementia. And many cases, vascular and Alzheimer's comes with in the same patient, mixed dementia. Vascular dementia?
not giving this kind of symptoms of the Alzheimer's.
No, this is a very early, in the early stage, you will have behavioral symptoms. The person will have very strong memory of his past events, but he will gradually lose the recent events. You have to go through the cognitive assessment first. Then you have to go for this medication. And when he is getting so many medications, there is a chapter called deprescribing. Deprescribing in this case, because many a times we see that the medicine that is going on, it has the course has been completed, but it is continuing. It has been giving twice a day, but it is sufficient to take once a day. Many a medicine, it is not at all necessary nowadays, but it is included in that medicine. In elderly person, very common is over the counter.
No, in that
no, I am telling for the students, always ask for over the counter medications in all persons, because the constipation medication, energy medication, vitamin, we are taking it for a pretty long time. There is no prescription, no doctor has prescribed that, but we are buying it and taking it. All these medicines have side effects. Even Ayurvedic medicines, natural medicines. They said, oh, these are Ayurvedic medicines. No. All the naturals are not safe, as it is presumed. Not. Many Ayurvedic medicines have lead as its component and have long-term neurological problems. So you have to ask for what? আর কি ওষুধ খান, নিজে কিনে কিছু খান কিনা, জাস্ট ডিরেক্টলি আস্ক দিস। সাবস্টেন্সের ক্ষেত্রেও যে আস্তে আস্তে জিজ্ঞেস করলে হবে না, ডিরেক্টলি আস্ক কি কি নেশা করেন। যদি পেশেন্টের মুখ দেখে বোঝা যায় তাহলে একদম ডিরেক্টলি অ্যালকোহল কতদিন নিচ্ছেন বা গাঁজা কতদিন নিচ্ছেন, ডিরেক্টলি আস্ক দ্যাট। বাট ইউজুয়ালি দে নেভার টক ট্রুথ। Okay, so directly you have to ask, and directly you have to ask what other medicines over the counter you are buying and taking for a pretty long time. These are things. All the medication history is very important. Sure.
Thank you, madam, for very insightful presentation and talk, I would say. And definitely, I think we could have had more questions, but anyways. And now I would request all the head of the departments in our esteemed faculty to please come on the stage for felicitation.
প্রথম দিন এলো এসেই বাড়িতে পড়ে গেল ফল এন্ড ফ্র্যাকচার হ্যাঁ হ্যাঁ থ্যাংক ইউ
এই সুদেশ তুমি
হ্যাঁ তুমি বাদ দিলে কি করবে?
আমি তো head of the I know Abhidar. I am very sure.
হ্যাঁ